The tagline for our internet series on gastroenterology is Name the Topic, the world experts are here. This is going to make a big news because news refers to a new EndoGE webinar series. I am Dr. T.S. Chandrasekhar, the course director. I represent from as a governor from the American College of Gastroenterology India region. I bring warm greetings from the scientific committee of World Gastroenterology Organization as a member and from MedIndia Hospital. Our previous webinar series attracted over 9,000 delegates from all over the world. That really inspired us to do more series of meeting. Now today is the meeting fourth one, webinar series 3, endorsed by American College of Gastroenterology, accredited by with 1 credit hours from the Tamil Nadu Medical Council, and is organized by MedIndia Hospital and MedIndia Academy. This webinar would not have been possible without the help from my colleague, Dr. Gokul Satyamurthy, Raji Yogesh, Dr. Prasad, and Tringyana Sambandam. And equally important is our webinar ambassador. What we have designed our webinars is we'll have one ambassador who is interested in academic propagation from various states of India, and international ambassador. We recently added 2 more ambassadors, one from Nigeria, Dr. Evaristus, and one from Sri Lanka, Dr. Bhavanta. And all of you get 1 credit hour from Tamil Nadu Medical Council. Those from other state also, if they apply to us in 24 hours, we'll give the certificate. You can show it in other your own state medical college council, then you get the credit hour. Also, that is very important. And this again would not have been possible, all this venture, without our academic partner, Micro Knowledge Academy and Micro Labs. The first webinar was inaugurated by Professor Dr. Jonathan Lighton in the month of April 2024 by the President of American College of Gastroenterology that set the ball rolling. And now we have lined up webinars from April 24 to March 25. And this is the various topic. The next topic ours is celiac disease and non-celiac gluten sensitivity, Barrett's esophagus, then met and unmet needs in hepatology and MASLD, and the other topic like learning aspects of colonoscopy and ERCP, fecal microbiota transplant and probiotics, high quality colonoscopy and endoscopy, H. pylori infection and GI malignancy. You name the stalwarts, we are able to get it, and we are very thankful to them. And in our September webinar, we are going to have none other than the Nobel Prize winner, Nobel laureate, Professor Dr. Barry Marshall, who is discoverer of Helicobacter pylori. He is going to tell us about how he discovered the journey of discovery of Helicobacter pylori and further. And please watch out the time alone, 5 p.m. to 6:30 p.m. according to the Australian, but in the Indian time. Don't miss out on 25th of September. We are almost got several thousand viewers for this webinar. We are going to have 20,000 webinar. Now we have the cumulative attendance of 6,130 total registration there. And now I have a pleasant duty to introduce my faculty. Without the good faculty and good topic, this webinar would not have attracted so many delegates from all over the world. And we have eminent faculty. I will introduce one by one as the program flows into that. After the program, we are going to have the panel discussion, and chit chat is a very important. Everyone likes it. Now I have a very pleasant duty to tell my very good friend and always ready to help us. everyone. He is the most popular among the academic circle. Professor Dr. V. Mohan is the founder chairman, Dr. Mohan Diabetes Center, Chennai, internationally acclaimed diabetologist scientist. If you want to tell me in one word, Mohan means his H index is 157. Now, those who are in the academic profile will understand how important the H index 157, and he has got several awards. I feel there need to be discovered some more award to really bestowed upon him. And Harold Alkin Distinguished International Service in the Cause of Diabetes Award by American Diabetes Association. And he has got a publication over 1,600. Maybe this is maybe the old figure. I don't know about right now the figure is, and H index is 155. Above all, he is very grounded and ready to help the our younger generation. This is the reason why we have selected him as our moderator for the topic. Now I'll hand over the mic to Dr. Mohan, who will introduce usually another eminent faculty, my friend Professor Dr. Usha. After that, we'll set the ball rolling for the proceedings of the lecture. And in between two lectures, we have a very pleasant task to launch something very important. Then after the end of the second talk, we'll have the panel discussion. We have the panelists will be introduced later, and we have a nice chit chat session. Thank you. Dr. Mohan, please.
Thank you, Dr. Chandrasekhar, for that very generous introduction. First of all, I must congratulate you for conducting so many webinars which are nationally and internationally useful, not only to gastroenterologists, but I think to practicing physicians, to students, postgraduates. And you have been continuously doing this for so many years now, and it's getting better and better, and I think the reach is getting better and better. So hats off to you. Continue to do the great work, and now in your capacity representing the American as a governor of the Indian chapter of the American College of Gastroenterology, you've got more responsibility, and I can see that you're involving everybody as ambassadors and national, international. So really you've kept the whole net very, very wide so that people have a great opportunity to learn. There is a great thirst for knowledge, but that knowledge, half of it is concocted knowledge. So when it comes from experts, it really makes a big dent, and youngsters are taught and mentored by people like you. And it's in that context that it gives me great pleasure to introduce Professor Usha Datta, a very eminent gastroenterologist of this country. She heads one of the leading medical colleges in the country. She is a professor and head of the Department of Gastroenterology at PGIMER Chandigarh. She is the editor-in-chief of the Indian Journal of Gastroenterology, is international editorial board member of the Journal of Gastroenterology and Hepatology. She is a founding member of the Crohn's Colitis Foundation Celiac Society of India. She is a clinical research interests include gallbladder cancer, gallstones, nutrition, and IBD. She has close to 500 publications. Her H index probably is much higher now, very high H index. Above all, a great teacher. So Professor Usha Datta, see, it's very easy for a clinician to do clinical work and to publish. But when clinicians are scared of biostatistics, for a clinician to come forward and to teach biostatistics for doctors, it needs a lot of courage. And therefore, I congratulate Dr. Usha Datta, and I'm sure she'll do a great job. We were discussing the other day how much time it will take to learn gastroenterology. When she was saying, in this time can I teach? And I said, lifelong is not enough to learn biostatistics. The field keeps on changing. But the whole idea is that you get inducted into the basics, so that then thereafter you can keep on learning. So over to you, Dr. Usha Datta. You can take over from here and speak, and then we will probably take the questions during the panel discussion. So over to you, Dr. Usha Datta. Yes.
Okay. Thank you so much for your kind introduction, and it's my great pleasure to be a part of this meeting so that I can share my understanding with all the people who are participating. It is a new area for clinicians, and it does have its own learning curve. So what I would here say is that what I'm going to talk about, what is research, how do you write a research question, how to choose your best study design, how to choose a key outcome, how to calculate the sample size, which statistical test to choose.
Dr. Usha, can you just share your slide first?
Go on, Dr. Usha. It's in. Yeah.
And how to interpret the results that you have got and how to report. So it's a very wide arena. So I'll just focus on certain parts which are conceptual for clinicians. So what is research? A clinician sees a problem, say all patients with diabetes, what new drug can we give for them? So this is the entire population of diabetes all over the globe. Now, no diabetologist can study all the patients, and that is why he or she will take a representative and an adequate sample, which is a small n. And then in this is where you need a statistician to help you with the sample size. And this small n of patients, maybe 50, 100, 1,000, 10,000, you will closely observe them, describe them with mean, median, proportions. So this is the part of the descriptive statistics. And then you will extrapolate it to the whole population. So you have discovered a drug, you want to use it, you want to tell the world to use it. So you are from your population wanting to extrapolate it to the whole world for them to use it for their patients. So this is where again statisticians are important for us to help analyze the data, interpret the data and extrapolate it conservatively and appropriately to the whole population. And that is where we need p-value, confidence interval, relative risk, odds ratio, risk difference, and NNT. And that is where we have our statistician friend coming in. And steps in research is you identify a problem, write it as a research question, write a hypothesis, calculate the sample size, get an ethical approval, write it as a protocol, register the trial, conduct the study, analyze, and publish. So here we need the N from the biostatistician, that is the sample size, and P from the biostatistician, that is the p-value. But this is a misconception. We need them all through the whole process to help us and constantly work with us in close collaboration, understand each other's jargon and involvement at every step. So the other option is to learn it yourself. How do you choose a good research question? Feasibility, it should be interesting, it should be novel, ethical, and relevant. The mnemonic is finer. What is the study design you should choose? It is descriptive statistics as one end, which is just one case report or a case series. And analytical statistics is whenever you have a control arm, and here you have the cross-sectional study, the case control study, the cohort study, and the randomized control trial. As you move from here to here, you have increasing validity and increasing impact. And we know that the systematic review steps on the top and the RCT is just below that. And editorials and expert opinions are personal opinions of experts. So the key terms are exposure and outcome. So in our mind, smoking is a risk factor and exposure, and the outcome is lung cancer. Other things are even when you give a drug like a vitamin D, that becomes an exposure, and the outcome is trying to reduce IBD activity. Nutritional status of the patient and mortality. So this is the exposure, this is the outcome. Our hypothesis being that those with lower nutritional status will have higher mortality. Giving biological therapy to induce IBD remission. Again, this is the exposure and this is the outcome. So the key terms, it depends upon, the key terms are exposure and outcome. And when we have the lighter one, I'm talking about controls. So the top layer is the cases, and this is the control. Unless you have a control arm, you cannot do a valid study, because otherwise there are so many variables. So the first thing we have to do is to have a good control arm. And it depends upon what direction are you looking at. Are you looking at from exposure to outcome or outcome to exposure? So we'll come to that, and under what time frame we are looking at. So these are the key terms in biostatistics for us to understand whatever study we are doing. On one hand are what are the parameters which are dictating the outcome, those are the exposures, and what are the outcomes we are looking at, those are the outcomes which are of relevance. The direction, as I said, is it from exposure to outcome or outcome to exposure? Now you see this particular snapshot, this is a cross-sectional study. I am looking at all the IBD patients who are coming into my outpatient, checking whether they are vitamin D deficient or not at that point of time as a snapshot. So this is something which is telling us our hypothesis is that patients with vitamin D, IBD have lower vitamin D levels. But we do not know whether it's the chicken or the egg, whether vitamin D deficiency is causing IBD or IBD activity is causing vitamin D deficiency. So the next method of doing it is a case control study. I'm looking at patients who are relapsing with IBD and another group of patients who are in remission and seeing whether 6 months back their OPD files had vitamin D status recorded at that time and whether they were deficient or not. So this is looking back after the outcome of interest has happened, the outcome of interest here being IBD relapse. And we are going back in time to see whether they were vitamin D deficient 6 months back. So this is a retrospective study. It is a case control study. And here we have the case and the control. And the parameter which we are looking at, the exposure variable, is vitamin D deficiency 6 months prior to the present status. So our aim here is, are IBD patients in remission now having a better vitamin D status in the preceding year? You can reword it as, our patients with relapse had a poorer vitamin D status in the preceding year. The same study can be done as a cohort study. Here we are having vitamin D deficient people and normal vitamin D people. We are following them up over a period of time, maybe 1 year or 2 years, to see whether they are more likely to have IBD flares. So this is going from exposure to outcome. So this is a classical cohort study. So here I'm saying that vitamin D deficiency is associated with increased risk of IBD flare. Note that with each study design, the way we interpret it is different. And here it is a naturally allocated group. Patients have just come to the outpatient. I divide them into 2 groups, vitamin D deficient and normal, follow them up over a period of time and see whether they are more likely to have an IBD flare. So cohort is a word from a Roman army of 480 men. It's a defined group of people marching forwards in time from exposure to outcome. So the crucial part about cohort study here is most of it is a prospective cohort study. We are going from exposure to outcome. For your left brain, now let us see how we can define this. We have healthy people here and we are studying their vitamin D levels and finding those who are vitamin D deficient are the red dots and those with normal vitamin D are the blue dots. We are separating them into vitamin D deficient and normal. And we are following them up over a period of time to see whether they have developed a flare or not developed a flare. Those who have developed a flare are the yellow dots. Those who have not developed have retained their previous color. And then we analyze them as relative risks. Number who have developed flare in those who were having vitamin D deficiency versus number who have developed flare among those who did not have vitamin D deficiency. And that simply is relative risk. So the same thing can be done as a randomized control trial. Here we randomly allocated our patients to receive oral nanovitamin D or placebo and followed them up over a period of time to see whether it led to disease reduction in their disease activity. So here we are saying that the oral nanovitamin D supplementation reduces disease activity in IBD. So I have given you 4 examples with the same thing about vitamin D and IBD, how we can look at it in different ways. So what is an RCT? You have study subjects, you randomize them again to receive intervention, that is the red dots, or the placebo, that's the blue dots, and follow them over a period of time and see who went into remission. Here the yellow dots are number of those who went into remission. And here again you calculate relative risk, number in remission divided by the total number who received vitamin D versus number in remission among those who did not receive vitamin D. So prospective versus retrospective, again, just to handle this confusion, prospective is at the time of enrollment. All studies are done from a point of time. That doesn't make it prospective. The prospective and retrospective word is dependent on whether the outcome has happened or not happened. And here you see when the exposure is before the outcome, that is smoking, and then develops lung cancer or pancreatic cancer. So that is going from exposure to outcome, and that is a prospective cohort study or a randomized controlled trial where you are giving vitamin D and seeing the IBD remission. In contrast, retrospective study, the outcome has already happened. So here we are seeing that the patients who have relapsed already, that is the outcome. And we are going back in time to see whether they were vitamin D deficient or not. So this is a case control study or a retrospective cohort that is beyond the scope right now to clarify that. So here I'm saying that smokers more often develop pancreatic cancer on follow-up. So that is our understanding of a prospective study. Whereas in a retrospective study, we are saying patients with pancreatic cancer more often were smokers. So you see the way the wording is going. Now we come to the research question. We use the PICOTS format, which population, what intervention, what comparator, what is the outcome of interest, what is the time frame, and what is the study design we are planning to use. So the research question in our RCT was adult patients with active vitamin D deficiency, active UC with vitamin D deficiency, receiving oral nano vitamin D for 8 days versus an identical placebo. Outcome is a 3-point reduction in UCDAI from baseline, and 4 weeks is the time point of our assessment. It's a double-blind randomized control trial. So the outcome which we choose should be predefined, patient-related outcome, clear, specific, measurable, and a continuous variable is better than categorical because that will help us reduce our sample size, and the outcome should be assessed in the same way for the exposed and the unexposed by an independent blinded observer so that there is no measurement bias. So effect size, another term which is used. Suppose a new person comes and tells me that drug A will reduce the blood pressure by 1 millimeter, I will not use it. Drug A reduces it by 5 millimeter, I will not use it. But the drug A is expected to reduce by 10 millimeter, I may start considering to use it. And drug A expecting to reduce by 20 millimeter, I will be a little worried about, making a drastic reduction. So here my effect size is 10 millimeter. So compared to placebo, if the new drug reduces the blood pressure by 10 mm, I may be willing as a clinician to start using it. Similarly, in our study, we used a 3-point reduction in UCDAI more than the placebo as our outcome. So how do we calculate sample size? Really, it's extremely simple. There are several softwares online. All that you have to do is plug in certain numbers and you will get your sample size. What do you have to plug in? I will just show you. You have to plug in alpha error, which is standard, which is 5%, power 80%. I usually use 90% so that, it handles my primary and secondary outcome to some extent. And effect size is this is where is your judgment. What is the baseline proportion, either from literature or from our pilot data? We thought that 20% of our controls will anyway go into remission, and that is from our clinic data. And then we thought that vitamin D group will have a 40% additional benefit in that group. So we thought the effect size is 40%, and we had to just plug these numbers in, and we got a sample size of 22 in each group, and we took 30 patients in each group to take care of dropouts. So what was the study design? Oral nano vitamin D, exposed, placebo, which is not exposed. You study all the baseline variables in this and go over a period of time with these patients to go forward in time and try and find who went into remission, who had active disease, who went into remission, who had active disease, and thereby we know this proportion is what is going to be our relative risk. So if suppose another example, I have 10,000 smokers, 10,000 non-smokers, I follow them up over a period of 20 years and have no loss to follow up, just an hypothetical situation. 100 develop pancreatic cancer, 9,900 don't develop. And here in this group, 10 develop pancreatic cancer, 9,990 don't develop pancreatic cancer. So from this, we will go ahead to understand how to analyze such a kind of data. So the risk here is 1%, that is 100 divided by the 10,000. So 10,000 people were exposed to smoking, 100 developed. So that is 100 divided by 10,000, that is 1%. And then here we have risk of 10 by 1,000. So that is 0.1. So what is odds versus risk? This is again a thing, just a simple way of depicting a slice of pizza by the remainder of the pizza is odds. Slice of pizza by the whole pizza is risk. So odds is number of people who have developed the event of interest, that means remission or mortality or whatever, divided by all those who haven't had it. And here risk is number of people who went into remission by the total number of people who received vitamin D. So this is the difference between odds and risk. And odds ratio is classically used in a case control study, and risk ratio is classically used in a cohort or an RCT. So let us now simply calculate. Here you see smokers 10,000, 100 people developed, and here you have risk is 100 by 10,000, and in the non-smoker group 10 by 10,000. So the relative risk is incidence of cancer among smokers divided by incidence among non-smokers, that is 10. That means the incidence of cancer among smokers is 10 times higher than non-smokers. Here we have gone from exposure to outcome. If you calculate the odds ratio, that is 100 divided by the remainder, that is 9,900, and divided by 10 divided by 9,990, you get an odds ratio of 10.09. Odds ratio and risk ratio can vary depending on what is the proportion in each of these cells. So the odds ratio of cancer among smokers is 10.09 compared to that of non-smokers. So this is how you will express it. Among those with lung cancer, the odds of being smokers is 10.9 times higher than being non-smokers. So this is how you express an odds ratio in text. And now we are seeing in a case control study in patients with ulcerative colitis who have relapsed versus those in remission. We have taken a sample and gone back in time and saw whether they were deficient or normal, deficient or normal. And this is how we do an analysis. Here, among patients who are IBD relapsers, 60 of them were deficient. Those in remission, only 40 were deficient, and you have 20 and 80 in each of these cells. So the odds are 60 by 40, that is 60 by the remainder, that is 40, and here you have the odds is 20 by 80. So among relapsers, the odds of being vitamin D deficient is 3 times higher than among non-relapsers. So the way we express odds is a tricky way because we are now going from outcome back to the exposure. So how do you express other outcomes? That is risk ratio or relative risk, same things. So risk in the drug arm divided by risk in the placebo arm. So that is risk. This is risk in the drug arm divided by risk in the placebo arm. Risk difference is risk in the drug arm minus risk in the placebo arm. So we are just taking the risk, say it is 5 here, and the risk here is 2, 5 minus 2, that is 3. And what is number needed to treat? Number needed to treat is very simple. It's 1 divided by risk difference. So we got a risk difference of 2, a risk difference of 0.5, then the number needed to treat will be 2. That means we need to treat minimum 2 patients to obtain 1 favorable outcome. If the relative risk difference is 0.05, the NNT will be 20, which means we need to treat minimum 20 patients to get 1 favorable outcome. Now, how do we judge the association? So now we come to p-value and confidence interval. P-value is probability of an observed association occurring purely by random chance is p-value. So this is the technical definition. Now, an association between 2 variables, 2 people can be together. It could be a chanced association. It could be a true association. Just 2 human beings together is a chance association. It could be a true association. They could be an husband and wife, or they could be dating couples, or they could be people who are working in the same institutions, or it could be a biased thing, like people who are together in the same cell in the prison. It could be they are just by chance together there. So, or it could be a biased association due to other reasons. I'll come to that. The crux here is because human beings have 5 fingers, agriculturists started this concept of p-value they just took this random thing of 5%, and that is what translates to 0.05. 5 divided by 100 is 0.05, and that is our magic figure of p-value less than 0.05. It just tells us that by random chance, two things could be together in only 5% times. That means 95% chance that actually there is some association happening. So we have just kept it a conservative 5% so that um, we can exclude or keep the null hypothesis. Now let me tell you a very simple game of Ludo which we play. I want a 6 to come out of the home, and my hypothesis is that there's an association between my wishing for a 6 and the dice actually rolling a 6. So what do you think is the chance? The null hypothesis is that there is no association between my asking for 6 and the dice rolling for 6. The alternate hypothesis is that there is an association between my wanting a 6 and getting a 6. So to test it, I just roll the dice. And here I actually get a 6. The probability that the dice rolls exactly what I'm asking for is 1 by 6 times. There are 6 faces for the dice, that is 17%, which translates to 0.17. 17% is 17 by 100, so it's 0.17. Now I again roll the dice and ask for a 6. And here I'm getting 1 by 6, 1 by 6, that is 1 by 36. That is 2.8%, that is 0.028. Now this is fairly uncommon for me to get 6 on both the dice, and I'm asking for it and I'm getting it. So that is very unusual. So that is less than 0.05. So it's happening more than chance. And here I'm actually getting it 3 times. I'm getting 6 and then 6 and then 6. This chance is 1 by 216, and that is 0.5%, that is 0.005. So this is really unusual for anybody to get 6 and 6 and 6. Sometimes it does happen by random chance, but when it is happening more often every time in your chance, then everybody suspects that maybe your dice is a little biased. And here comes the role of Shakuni, how he manipulated his dice and kept it biased to get him whatever he wanted. So if it has rolled only once and you got 0.17, it could be just a random chance that you got it. But when you again and again and again you're getting it, then there may be a true association. So you have to rule out a biased association before you say that it's a true association. Or it could have been a coin from Sholay that wherever he put up came only heads. Now, what is confidence interval? As I said, we have drawn a sample, analyzed this sample, and we are extrapolating it. When we extrapolate what we have got in our study, maybe a relative risk or maybe an odds ratio or maybe a proportion, when we extrapolate, we need a confidence interval. Now, confidence interval is by a simple formula, mean plus minus standard deviation square divided by root of the sample size. Now, if you see, if the sample size goes on increasing, your confidence interval will go on decreasing. If the variable has a very wide standard deviation, then obviously that will increase the confidence interval. Suppose I think of any parameter which can have a very wide standard deviation, like maybe the height of a person, in contrast to the serum albumin of the person. Serum albumin will stay within a very narrow range, whereas the height of the person can vary a lot in the globe. So for seeing such a kind of outcome, I will need a larger sample size. So if the outcome parameter naturally has a very narrow standard deviation, I will anyway get a smaller confidence interval. And if I have a larger sample size, I will reduce my confidence interval. So whenever we choose these parameters, it will tell us also about...
Dr. Usha, it's 7:35, but you can, do you have, how many more slides do you have?
I'll finish another 5
No,
minutes.
no problem, no problem. Just a gentle reminder,
So,
that's all.
thank you. So again, simply, if you do confidence interval with the parameter here, you have confidence interval of 12 plus minus 1. And what it actually means is repeatedly, if you sample the population and then you get the means of all these population, all these means 95% time will be between that confidence interval of 11 and 13. So all that you're trying to say is when we extrapolate our sample to the whole population, how narrow it would be. The narrower the confidence interval, the better it is. So here in a forest plot, narrow confidence interval not crossing 1. It should not cross this line of 1, and it should be as narrow as possible. That means it is a better confidence interval. So chi-square test, you see obesity and hypertension. My null hypothesis is that there is no relationship, and if I have 100 patients in each of them, I should get 50-50 in all of them. But I'm actually getting 55, 45, 45, 55, and this p-value for this association is 0.20. I expected this, but I'm observing this. My observed value is different than the expected value. So I'm not able to reject my alternate hypothesis. So there is no relationship between obesity and hypertension. But if I had got 60, 40, 40, 60, my p-value becomes 0.007, suggesting that there is some association between obesity and hypertension, and this p-value is less than 0.05. So there is an association. So if I follow up patients of anything and develop, say, colon cancer, this patient has contributed to 4% years, this patient has contributed to 3% years, this to 2 and this to 1, and we have total number of people outcome has happened in 2. So that is 2 cancer per 10% years of follow-up, or you can also call it 200 cancers per 10,000 years of follow-up. So why do we randomize? We randomize to remove selection bias and to balance both the arms for confounders. And we randomize so that there are several factors which go in to see our observed effect. We are trying to take all these effects off before we can say that it is what we are giving the drug is causing the observed effect. So we have to randomize so that all these components are taken off. And if we have small sample size, we can have unequal numbers. So we use permuted block randomization, or you may have different distribution of certain variables. So we can do stratified randomization, and I will not go into confounders. I will not go into blocking. Blocking is permuted block randomized size of varying block size would be useful. And we have randomization softwares. We blind means being unaware of what the patient is getting. This is to eliminate measurement bias and to eliminate performance bias so that we are handling all the patients in a similar way. Randomization can be done and a list can come up. And you conceal the allocation by either a serially numbered opaque sealed envelope or a serially numbered identical vials. And then from pro forma to p-value, you have to choose these 5 tests, 5 basic things. So you have to decide whether the person is having 1 group, 2 groups, or more than 2 groups. Say obese people, I'm looking at cholesterol and triglyceride, that is just 1 group. Or I'm looking at obese versus non-obese, I'm looking at hypertension, that is 2 groups. Or more than 2 groups is obese versus overweight versus normal, I'm looking at hypertension. The next thing I have to see is what is the kind of variables. Is it categorical, that means male or female, which states they belong to, ordinal, that is socioeconomic status, or grade 1 to 6 or murmur, scale, whether it is a number or a discrete number or a value. And then I have to see whether it is normal or skewed, symmetric or asymmetric. And normal, I will distribution, I will express it as mean and standard deviation. And here I will do it as median and IQR. And the distribution is normal or skewed. I can use several methods on the software. I use SPSS on the PP plot. We can use the Kolmogorov-Smirnov test and look at the histogram, decide its normality. And we express it by box and whisker plot. You have the median here, the 75th centile and the 25th centile here. And the next important step is what is the sample size. If the sample size is less than 30, even if it is normally distributed, consider it as a skewed distribution and applied skewed test. And if it is more than 30, you see whether it is normally distributed or not and decide accordingly. Larger the sample, more robust it is, the statistical assumptions. If it is related, this is very important, pre and post blood pressure. Pre-treatment scores, post-treatment scores. These are related in the same patient, and right eye, left eye twins, match control. So in these are called related samples. They have a different way of analysis. So which statistical test? This is most important, and just pay a little attention. Categorical versus categorical. That means obesity versus hypertension. Both of them are yes, no, yes, no. I will use a chi-square test. If they are matched, that means I'm looking at pre-treatment red eye and post-treatment red eye, I will use a McNamara score. If the expected value in any of the 4 cells is less than 5, I will use Fisher's exact test. Okay. Now, categorical versus continuous. Now I'm having an unmatched thing, that is obesity versus non-obese. Two unmatched independent groups. I'm looking at what is their blood pressure. So, and the blood pressure, it is normally distributed. I use student t-test. If the blood pressure is not normally distributed, I will use Mann-Whitney U test. If it is matched, that means I told you it's a matched sample or it's a pre or post, then I use a paired t-test if it is normally distributed. I will use a Wilcoxon sign rank test if it is a skewed distribution. And if it is more than 2 groups, then I use ANOVA for a normally distributed or a Kruskal-Wallis for a skewed distribution. If it is continuous versus continuous, that means triglyceride versus cholesterol in the same patient, it is continuous variable. I will see if it is normally distributed, I use a Pearson correlation coefficient, or I use a Spearman's correlation coefficient. So Pearson R or Spearman's rho. So I can stop here and sum up. Okay. So the key 5 steps are hypothesis. You have a hypothesis, you plan your analysis, organize your data, use a statistical program, check the 5 things which I have said, 1 group, 2 group, 2, 3 groups, is it normally distributed or not? What is the sample size, more than 30, less than 30? How is the variable? Is it just a category or is it a number? And or is it just an ordinal variable? Are they related to each other? Apply the test and interpret and present it in text and graph. And this we have already discussed. Don't fish for p-values. Have it a priori analysis. Don't avoid subgroup analysis unless it's pre-tested, or avoid multiple testing. I like torturing my data till the data confesses. So please don't do that to get more p-value, because research is contributing to science and science is search for truth. Our research is going to be a drop in the ocean. Keep it pure. We need appropriate research methods. Thank you.
Thank you, Dr. Usha. I know it's extremely difficult to cover a topic like this in such a short time. You have done a marvelous job. I think next time TSC should give you 2 hours for this, then you can do it. But still, it's as we said, we cannot teach everything. You can't teach driving in half an hour. You can't teach swimming in 10 minutes in a video. You still have to get into the thing. You have to wet your feet and wet your hands, and only then you can actually do it. This is more to spark your, actually that summary slide of the various tests you use, I think was one of the most important, and I hope people took pictures of that. So congratulations, well done, and we will try to involve you in some of our programs as well. Some a clinician teaching statistics is very different from a statistician teaching statistics. Well done, madam, you've done a great job. I'll hand over to TSC now to go to the next topic, and stay on because there will be questions, and after the panelists come, there'll be a number of other questions taking over exactly from where you left. So thank you very much.
Thank you so much, sir.
And Dr. Usha, you did a fantastic job, and particularly bringing Saguni and Sholay. Fantastic job you did it, and the sum up slide. And
you should teach us the secrets though of what Saguni did, so we cannot solve those things.
Mohan, I think you got a point. How all the time you got it, but that the dice made up of bones, not the regular ones. Anyhow, not going to the detail, but you put it in a very subtle manner. The Saguni and the Sholay, the same coin on either side, same thing. And the other one is the sum up, very good. And what I liked is most is you have to be very pure, and you have to be very ethical, honest. You should not torture that cartoon. I liked it till it confesses to your wish and will. Anyhow, we will take up more question, Dr. Usha. I'm very proud of you. And next we are going to introduce, and after introducing the Dr. Jayanti, Dr. Jayanti is going to moderate the second session as Mohan to enter India, and Dr. Jayanti is for gastroenterology. She is a consultant gastroenterologist, hepatologist, Clinical Health Society Chennai. She's a pan-India teacher, and she's passion is only teaching and doing publication. She's a project expertise include Buchiari syndrome, gallstone disease, hypertension, and NAFLD. Now it is called a MASLD, and her interest is wide varying as the time needs. Need-based research will do that, and she's got 420 publications. Now I have the pleasant task to hand over a mic to Dr. Jayanti to introduce our other speaker. While he is going to share the slide, the second speaker, we have a very pleasant task of the launching a new. Dr. Jayanti, please.
Thank you, TSC, for this nice introduction. We now have our next speaker, Dr. Babu Mohan, who is a consultant gastroenterologist at the Orlando, Florida. He's an editor for Biostatistics, Journal of Gastrointestinal Endoscopy. He has over 100 PubMed cited publications, and he is the first author in almost more than 50 papers. His total publications exceeds 400. And I think his major interest is supposed to be well known for his clinical and research interests in meta-analysis, a problem which I always feel is one of the most difficult topics that can be taken up for a publication. And also he's interested in artificial intelligence and GI practice. I think I request Dr. Babu Mohan to make his presentation, and you take up the questions.
While you are thank you, Jayanti. While you are sharing the slide, I just want to have a very pleasant task, all of you faculty and the panelists and ambassadors to join. We are going to have a launching of the very important initiative, and you can't get a better person than Dr. Mohan, who not only worked very hard from his medical student days, and now he has got over 1,600 publications with this. So he is the apt person to launch this initiative. So launching by Dr. V. Mohan. And what is he going to launch? I am just already tell you that Mohan will have a very pleasant task requesting you. So once you click the button, and that launching will happen. And I request all the faculty to join Dr. Mohan to bless the initiative, and that is going to be a very good initiative for the many youngsters to start a research publication. Dr. Mohan, you can...
I can press the enter button. Enter button.
Yes.
Nothing happened.
Yeah, it will happen. It takes some time.
Oh, okay. Yes, it's coming.
This is launching of Pan-India Gastroenterology Research Study Group for multi-center study. Now, Mohan, I was talking to him few months before, he said nowadays TSC is very difficult to publish unless you have a multi-center and multinational. That really inspired me. Now I am holding the post of American College of Gastroenterology India region, that governor post, and we have around 1,200 members, ACG members, and other very active gastroenterologists all over the country. Why not I start this? This is what it is. Dr. Mohan, you are launching, and I want all faculty to support us. How do you think, Dr. Mohan, this is about Pan-India Gastroenterology Research Study Group?
Yeah. So, I always say that, I've written it in my autobiography also, that there are two types of cakes you can have. One is you can have a small cake which you can hold in your hand, and you can say that this cake is mine and this is only mine, and therefore I'm going to eat the whole cake. And that's also important, because making your own cake and eating your own cake is also very important. Or you can have a cake as big as this room or as big as this house, and you might have only a small portion of it. You cannot own that whole cake and you cannot eat that whole cake. But the portion that you hold will be bigger than any cake that you can make or you can eat. So that is collaboration. So a good example of that is the PURE study. I know cardiology better, but I'm sure in gastroenterology also it is there. In diabetes we have. There's another example from India itself, the INDIAB study. The INDIAB study is the largest epidemiological study done on diabetes in the whole world. 124,000 participants, representative of India's 1.44 billion. Every state in India representative sample. Now, how did we do this? We did it by having 31 collaborators who each of one was PI for one state of India. So the local people were taken, this PI was involved, and all the 31 of us were authors, and it was all in Lancet and big journals like that. Now, if I had done it only in Chennai or I had done it only in something, it will go into some much smaller journal. It cannot go into that. So that is the power of collaboration. You can do your own research, you can publish your own research, but always think of a bigger picture, because you'll also get regional variation. What you get in US, in the Indians living there, may be very different from the Indians in India. What you have in, say, northeast of India will be very different. Just to give you an example again, the prevalence of India in all the states, when you take, the prevalence was 4% in Bihar, in the whole state of Bihar, representative sample, 4% in Bihar and UP, and it was 26% in Kerala, Goa, Puducherry. We would never have known this. In fact, I was doing my studies only in Chennai. Only my daughter came and told me, we have to do this big study in India, whole India we have to study. Who would have thought from 4% to 26%, the prevalence of diabetes will vary. Now, having done that, now you can ask, why is it 4% in one state and why is it 26%? Is it genetic? Is it this? It will go on and on. Your whole life you can keep studying. So you have to trust each other, and you have to form a group of people exactly like what TSC has now put together. Doesn't mean you can't do your own research, doesn't mean you're giving away your whole data or your life or everything, but apart from doing your own, share it. So instead of having massed, let's say 500 cases or 1,000 cases, you may have 100,000 cases, which you'll never be able to get. And that will then, people will then look up, and they'll say, we want this in Lancet Gastroenterology, or we want it in Nature, or we want a Nature Medicine, or then if you want to go higher and higher, there is no other way other than to collaborate. And that is why I think forming this pan-India, and it's come at the correct time when the the governorship of the ACG has come to Dr. TSC, and I would strongly encourage all of you. What I also told TSC is, don't take up just one topic. Different people in India, maybe one will be interested in liver, one will be interested in the IBS, one will be interested in pancreas, one will be interested in something. Get them all together, divide that into different groups of people. Maybe 5 people, 10 people coming together. But the power of 10 is much more than the power of 1. Start doing that, and India's data will then soon start getting quoted everywhere. Not a single paper in the world now does not quote ICMR and DAP study. Because 124,000 people, representative 1.44 billion, China has not done it, US has not done it, Australia has not, nobody has done it, but we have done it. And we did it because all the diabetologists in India joined together to do that. So I think it's a fantastic concept. Now to put it into practice, today is a day, launch is a historic day when you launched it. Please subdivide it into different groups. Think of the research question, what is the question they're trying to answer, and then formulate it. Lot of things as telling TSC can be done even without funding. Even just asking, through Delphi, through things, you can, or take the data which is already published in India, pool it, do the meta-analysis which Dr. Babu Mohan is going to talk about. That itself can be a start. And then you start applying. Some things may be finished in 1 year, some may take 3-4 years to do. Don't worry about it. Have your plan, work together, and as Dr. Usha said, let's be honest. Let's not cook up data. Let's give the actual data, even if it is completely opposite of what the West is saying. Doesn't matter. Maybe you're on to something very big. In fact, if it's different from what they've done, it's even better for you. Don't be shy to say something which is completely opposite of the current view. And things in medicine are changing all the time. So what you publish this year may be different from 10 years down the line when India progresses. So I think this is a great start, and congratulations to you.
Thank you, Morgan, for your nice congratulatory message. That was in my dream, that when I started reading that Dutch group of pancreatitis study research group. Now it is being quoted all over the world, because all the people, pancreatitis, those who are interested in Dutch, the Holland, they join together and they make a big publication. Now it is quoted all over the world. So I thought of idea as a pan-India, and is the right moment has come, and we have divided into several sessions. Someone interested in endoscopy, luminal disorders, mortality, liver sciences, and pancreatobiliary division and transplant sciences and artificial intelligence. Here I may request you first study I may like to do with you, Mohan, in diabetology or something like fatty liver, anything. I
Sure.
can bring in all the people who are doing in India. We can do it under you so that it will be a good. The second thing I want to do with this, a lot of people are using intravenous conscious sedation. Why not all the anesthetists put together? What are the things, the results and other thing? Anyhow, it will go on like that. Now we are waiting for the second talk. And thank you very much, Dr. Mohan, for this wonderful.
My
The
pleasure.
lecture session continues now. Dr. Babu Mohan, you can share your slide.
Thank you so much. Thank you very much. I've shared the slide, and I think my video and audio
Yeah,
is
yeah,
all on. Please stop me
yeah,
anytime
I
if there
see.
is any problem with the slides.
Okay.
So my topic today, is about meta-analysis, selection of a topic, all the way to publication. What I'm going to share today is all from my personal experience. Now, as Dr. Usha Datta Madam just showed, meta-analysis, systematic reviews, they do hold the topmost level of quality of evidence above randomized control studies. But then, with my experience of doing all these papers, I must tell that there are bad meta-analysis, there are good meta-analysis, there are people who would say any data is better than no data. So it is up to us, as clinicians, to be able to figure those out. Let's say there is a meta-analysis of 10 randomized controlled trials, and if each of those randomized controlled trials are adequately sample sized, are well randomized and well done, then you can imagine that a meta-analysis from those randomized trials is going to be a very good data to report, and that would be a good meta-analysis data that can be used for patient care purposes. At the same time, there is meta-analysis. Let's say you have two good randomized control trials, and then there are 5 or 6 randomized trials that have biases involved in those studies. You could still do a meta-analysis. You can still report the information. Like I said, some information is better than no information. But at the same time, it's important to report, is it good information or is it bad information? Are there limitations to those published information, and what should future studies look at? So I personally believe that no data is bad data. Any data is always better than not having any data. But at the same time, it's important, it is our duty and responsibility to report the limitations of those data. So I wanted to start my talk, by letting this know that meta-analysis and systematic reviews, even though they are on the top of the pyramid, we still have to be aware of knowing which ones are good and which ones are bad. The general idea of doing any study, like what Dr. Usha Datta Madam just said, meta-analysis also involves the same thing. It all starts with a research question. Now, why does somebody want to do a research? Is it the passion to do research, to get the numbers, to improve patient care, to advance science as overall? Or maybe it's just the need, like for myself, my need to do research was to get a US green card when I started. But then just that one need would not have made me achieve what I've achieved so far, because I did have the passion to do research. At the same time, having trained from India, from Madras Medical College, there is always that ethics component that we are always taught very young on, from our first year of medical school. So we always take that particular care to make sure that the ethics is never lost. What we are doing has to be a good study. No, don't crunch the data to make that p-value significant. And in most of what I have done, I always explain my limitations and make sure that my study is not just the golden result, but it leads on to future studies. With meta-analysis, once you have the research question, the next step is to do a literature search. This can be easily done nowadays. In this picture, what I'm showing is basically what I used to do when I was in my medical school. Going to the library, getting a journal used to take 2 or 3 weeks. Like there would be journals, but then if you want a particular article, to get that from the librarian, it used to take weeks in the past. But right now, we have everything in our fingertips. We have everything on our phone. It just takes 5 minutes, search on Google Scholar, search on PubMed, see if there are enough studies to do a meta-analysis. So a meta-analysis involves the summarization, the pooling of data that has already been published. So you could have a good research question, But if there is no studies published on that topic, you cannot do a meta-analysis. So that's what I mean by literature search. And I also tell students and residents who work with me to also check for the feasibility, which means you should have enough studies to do a meta-analysis. At the same time, you don't want to repeat a study that has just been published last week in a major journal. Then you cannot really sell your paper. Collecting the data, analyzing it, getting the results, your primary outcome, your secondary outcome, writing the manuscripts, and then submission files. And that's what I'm going to go step by step, and which I kind of touch based, like research question, why, why are we doing this? What is the need to do this? To advance patient care, or is it your passion, or is it your career advance? At the same time, the last couple of slides that Dr. Usha Datta showed, very, very important. When a study question comes from the bedside, to advance patient care, it's always going to be a good topic. It's always going to be a good study. And then with literature search, you search for the feasibility, you check on Google Scholar, you check on PubMed. And once you know that your topic has the material to be done as a meta-analysis, the next step is to write up the search protocol. So I have kind of summarized the usual thing. Many of the librarians, the medical librarians, they have an online form that you can directly fill in, put in the question, what databases you want to search. Based on the PRISMA guidelines, you should have at least 3 major databases that the librarian should search to get the studies of interest. Make sure that your inclusion and exclusion criteria are predetermined. So all these things should be predetermined so that you don't change as the study is progressing. Otherwise, that would include, or that would induce bias in your paper. What outcomes are you interested in measuring? What suggested search terms, like what search terms would you use? Suggest those to the medical librarian, and the librarian can always change or modify those to get adequate literature search done. What publication date do you want to include, and are there any known works that has been published, which greatly helps the librarian to understand what is in your mind, and they can get the appropriate literature search done for you. So once all the studies are collected, the way our team works is on Google Drive. So we have Gmail ID for everybody. We have a Google folder, Google Drive. We form a folder, add all the studies of interest, download all the PDF files. And the main lead author, the majority of the papers when I used to lead a few years back, so I would create this data sheet. I would write all the name of the studies, make sure all the columns are appropriately labeled. You can always add new columns as you keep collecting data. So as you progress through the data collection, it doesn't mean that the data is final until it all goes and then cleans up to form the main table. But at the same time, the data sheet keeps on improving and then editing. And once you go like 5 or 6 rounds of editing your data sheet, I keep in mind that this sheet was going to be transferred as my table 1 or table 2 when my paper is getting ready to be written up. So I will touch base on those during the end of the slides. So that's data collection basically, because once you label everything appropriately, all the team members, they know what information needs to be collected. Analysis. Multiple softwares are available. The one that I like the most is comprehensive meta-analysis software. I don't have any shares with this company, so I'm just putting it here because my goal today is to let you know what I personally did. It has a very user-friendly window. You don't really need to remember any codings or formula to enter. All you have to do is just copy paste the data from your Excel sheet onto this software. And if you know how to use the software, it just takes 4 or 5 clicks to get your pool rate, to get your heterogeneity, to get the forest plots, to get the publication bias, all those information. And recently, many meta-analysis have started reporting trial sequential analysis, which is basically arranging the studies based on the year of publication, and with each year of publication they also report the pool rate. So with that kind of analysis, you can see that after certain number of years of publication, if the pool rate does not change, you can safely inform your readers that even if there are 5 new studies published after 2024, your pool rate is still going to be the same. On the other hand, if with each published paper, when you are pooling the rate according to the year of publication, if your pool rate keeps changing by significant number, more than a decimal point, then you can tell people that you still need future studies, because your pool rate might change if there are new 5 studies published in the next year. When it comes to the results section, Prisma checklist, Moose checklist. So Prisma is the preferred reporting items for systematic review and meta-analysis. Moose is more for observational studies. They have a checklist that is available online. You just have to make sure that you go through all the checklist and make sure your paper is addressing all those points that they want you to make sure that it addresses. Study characteristics is what I start off as the first paragraph in my results section. I write at least one paragraph of patient characteristics. If you're doing a paper on, let's say, endoscopy ultrasound guided liver biopsy, it is important to know what are the patient characteristics, what is their general age distribution, how many male, how many female, are these biopsies being done for parenchymal liver disease, most often, what type of needles were used. So the study characteristics would tell us, are there retrospective studies, are there RCTs, prospective studies, or population based studies. And then the patient characteristics will give the reader an idea what is the characteristics of the patient population that has been included in this meta-analysis from those included studies. And very important to report the risk of bias. So risk of bias is each individual paper's risk of bias. When a reader is reading your meta-analysis, it is like a one-stop shop, like you are summarizing information from 10 papers. So they are getting to know the summary of results of all those 10 papers combined. So it is your duty to let the reader know each individual study, what is the risk of bias involved. There are multiple tools to assess it. Commonly used one is Newcastle-Ottawa scale for observational and cohort studies. There is for randomized control trials, there is a very easy tool called Jadad scale. None of these scales or tools are like perfect in to say, but just use whatever you feel is easy for you to use and report the results plainly and openly, so that the readers have an idea of the quality of the studies that has been included in your meta-analysis. The pool rates automatically follow, that's your main goal of reporting in your meta-analysis. Generate the forest plots. And the next very important section of the result should be validation of your results. Does your result mean that that's the end of story for this particular data or this particular research question, or does your results indicate that there needs to be more stuff done in that topic? So heterogeneity is a very important aspect. Very commonly used statistics is the I-squared statistics. I also use 95% prediction interval to explain the distribution of the results in the real world from what your meta-analysis reports. At the same time, when you have a high heterogeneity, many people think that the data is bad or the meta-analysis is bad, but then your role is to do subgroup analysis, do sensitivity analysis, or a meta-regression analysis to teach the readers more or to inform the readers more of in which area do you think your results are more appropriate and in which area you think more studies are needed. So this forms a very big part of any meta-analysis study, which is reporting the validation, the heterogeneity, the publication bias, so that people understand that in EUS guided liver biopsy, these are all the variabilities that's available out in the literature that they can find in your paper, and what future studies need to do to address those limitations. Then comes the manuscript writing, the usual standard format for any manuscript writing, starting off with introduction, methods, results, and discussion. What I do when I am collecting data for my meta-analysis paper, I'll again take the example of EUS guided liver biopsy. Let's say I have 10 papers that looks into EUS guided liver biopsy. Now you can imagine that all these 10 papers are talking about the same thing. All patient population are patients undergoing endoscopic ultrasound guided liver biopsy. So they're all going to have the same goals. All those individual papers, they have the same aim and same background. So when you read those papers, collecting the data, you can actually formulate your own introduction. Now, the reason why I bring this up is more for young trainees and young students and residents who have no exposure to what an EUS guided liver biopsy is, people who do that on their daily life, I mean, they don't have to do this, they automatically can write their introduction because they're already involved. Now, that is the job of the senior author or the senior mentor to guide young researchers. But again, everybody's busy. So that's what I faced in my personal journey, is that I would wait for the senior authors for months, to help me to write the introduction. But then I decided, like, why not I just write it myself from all these 10 papers, let me get all the salient features, all the important points that they're discussing. And then while your data collection is being done, your introduction is already ready. At the same time, I also make points for my discussion section so that the methods usually doesn't change. It's the same statistical methodology for any meta-analysis paper. Your results, you know what to write based on the information that you have collected. But if you have these important points that each of those 10 papers are talking about in their discussion section, you already have 3-4 paragraphs what points you need to discuss in your discussion section. Again, something that makes your life easier, because your goal of starting a research topic, you should already know that your job is not done until it gets published, which means you have to write the whole thing at some point. So why not start writing it while you're collecting the data? Then comes the submission files. Every journal has their own, various criteria of what they need. But usually you need a cover letter, you need a title page where all the author's information goes in. Some journals like to have a separate document for abbreviations, write your manuscripts. When you're saving your images from the software, each forest plot image, make sure it has to be the 300 dpi quality. I do that at the same time so that I'm not spending time again, addressing these things. Get your supplementary file ready. And that's it. You have all your documents, all your files ready for submission. And like I said, our team right now, it's like an international collaboration. I have my own website where people email me, contact me. I just tell them, give me your Gmail ID. That's all I need. If you have a research idea, perfect. Check for the feasibility. We all work on Google Drive. Learn how to use Covidence software. That is something many medical librarians, they would search the literature and they will give you the link for the Covidence through your email. You go to the Covidence, each article reference comes up and you read the title, you read the abstract, you decide if it has to be selected into your meta-analysis or not selected. 2 different reviewers will do that simultaneously, and then the software will give you how many article references you agree and how many you don't agree. CMA software is what I mentioned, what I use personally for my analysis. Irfan View Image Editor is a freely available software, works only on Windows, where you can easily edit your images, convert them into 300 dpi, save them as whatever file format you need. Mostly I do TIFF, TIFF or JPEG format. EndNote is a software which is a reference manager software, which I have been using for many years. So I just stick to that to manage my references. But there are a lot of other freely available softwares too. And with the upcoming AI mediated tools, ChatGPT, the latest version, one of my residents who works with me told me that you can actually upload PDFs and ChatGPT will extract the data for you. So that's like saving some 3-4 weeks of your time that you upload. I think you can upload like 10 or some PDFs at the same time, and it will collect all the salient information and kind of, I mean, I've not tried that yet, but one of my residents said that it is doable. If you can do that, then you just have to cross check and verify the data, and your data collection might be done sooner than what we have been doing. Other tricks that I've used to get research questions is to read online first articles in journals. You know what are the upcoming topics, what new stuff are coming out, and that will help you to to get online, newer research questions, attending conferences, networking people, and sometimes just ask ChatGPT, and ChatGPT might give you a good research question. And I already went through the tricks I used for my introduction section, how I write it up while I'm collecting the data. When you're doing the data collection table, make sure you're editing it in such a way, never delete whatever you have collected. So I always duplicate the sheet to make sure as I'm keeping on moving through the sheet, the final sheet becomes my table for my paper. And then the discussion section, like I mentioned, note down the important points so that you can use them to write your discussion thing. For people who are interested to collaborate, forestplot.com is one avenue, but with Dr. T.S. Chandrasekhar's new initiation, I think that would be a great platform for everybody to collaborate and do more papers, out of our team. That's pretty much it. Thank you so much for your attention.
Now I invite
stop.
all the speakers, the moderators, and the panelists to come into the common platform. I just want to start with Dr. Mohan, then Dr. Jayanti, then the panelist, then the
I think we can introduce the panelists first, no?
Yeah, we have to introduce. And Babu Mohan, you made it very simple.
Yeah.
That systematic review and meta-analysis. It felt like that I can do it tomorrow itself. But after
Thank you so
going
much.
into the depth of it, it appears that so many software you need to have that, and it is a collaboration of your gray matter and your software and the need of the society, everything there. And I will just introduce the panelists now. So this is a session we are going to have more clarity of what exactly you want from our speakers and moderators. We have 5 eminent panelists here. Dr. Tayu, right now he is in USA. He has been a consultant, senior gastroenterologist, worked both in government sector and the private sector. Dr. Prem Kumar, he is holding the prestigious post of professor in HOD, Department of Gastroenterology, Madras Medical College. Dr. Pramanayagam, who has been a very good student now, is working as a consultant gastroenterologist, Apollo Hospital.
Evening, sir.
And Dr. P. Ganesh, again, he has worked as a professor in a government medical college. Now he is holding the post of professor of gastroenterology, Sri Ramachandra Medical College. Dr. Loganathan, again, both have been in government sector and now working in Apollo specialty. I have made a mix of the both working, has worked, and now currently working in private. So with this, after that, we are going to have a lighter session for 15 minutes for the chit chat. Now, before we will start the panel discussion and this one. Dr. Pirma, you are seen there. You want to ask the first question to Dr. Mohan and other.
Sir, am I audible, sir?
Yeah, you're audible.
Yes.
Good evening, sir.
Good
Well, it was a very interesting session. We had both about an introduction to biostatistics for doctors as well as how to do a meta-analysis. And before I go into the set of questions, just interested, how long does it really take for for doctors to make some sense of this biostatistics and get into publication? Particularly, it sounds a little difficult. It's easy to grasp when we listen to a lecture, but how to put it into practice? I mean, odds ratio, risk, relative risk. Every time I hear, I think I have understood, but the minute I go over it, I mean, it seems to evaporate. I mean, how do we get into this?
There is no tutorial by which Dr. Usha did a fantastic job. But if she were to repeat it even 3 times or 4 times, it is not that we are going to become very good in statistics. You have to get into the actual research, because learning the theory part of it is one thing, knowing where you use those, as I said, that one slide itself had that multiple testing. You do a small sample, you use Fisher's test, then you do ANOVA, then you do. So that part is okay. Now you have data, okay, and now you are applying the data, using that. Then the reviewer will teach you and say that, no, this should have been, that should have been done. So ultimately, it's a lifelong learning process. There's no question of, if you ask me, I've been in this field for 50 years. If you ask me, have you learned even after 1,700 publications, you ask me, do you know statistics? I know probably a scratch of it, little bit. I may tip of the iceberg, I may know. There's so much I don't know more than what I know. So it's a lifelong learning process, and each time, newer methods are coming, newer ways of analysis, big data and all, which you never even handled earlier, is coming. Earlier we would have been talking about 50, 60. Now we're talking about 10 million, 50 million. So it's a different ball game altogether. So lifelong you have to learn. A student keeps on learning and a researcher will keep on learning. So don't worry if you don't know anything. Yes.
That is the one I think you pointed out nicely. I think I want to respond to Prema also, the answer to me also. I was also wondering. I listened to Usha. It was next day. Tomorrow. I'm going to. But now after that, start writing it very difficult.
Usha herself
And
will
you
not be
asked
able to do that. She has to learn to do it
But
herself.
one thing you made it very confidently that you don't have to know everything about statistics.
You don't have to know anything. You start
Answer the
like learning
question.
swimming, jump into the water, and then you start. You will learn. That is
Answer
how
the
it is.
question to the problem you have. No, Usha, you
Yeah.
want to respond to
Yes,
Dr.
yes,
Prema?
Usha. Yes,
Yeah,
Usha.
I thought that an immersive learning process
Correct.
for minimum of 6 months means you are learning it every day. It's like, if you want to learn to drive a car, first day of every month, if you drive for half an hour, you will never learn. You have to learn it every day for your neuromuscular circuits to come through. So there are several online courses. Now YouTube has a lot of little things together. Harvard runs online courses. McMaster runs online courses. Dr. K.S. Reddy's institution, Population Research Institute, they run courses. So it is important to do a course and do the assignments within the course, apply it in your own research, and whatever you don't know, you plug it in with a little bit of YouTube here and there. And I think it is very important to go through a structured curriculum. Otherwise, everybody will learn swimming ultimately for survival. But if you go through a structured program, you can learn it faster and be confident of what you have learned.
But
So
Dr. Usha, you would agree with me, driving and swimming looks easier than biostatistics. That one point I will not agree. But one thing, Brahma is the secretary of Tamil Nadu ISG, and I've been wanting to have Usha, maybe under the supervision of Mohan, to run 1.5 days course or 2 days course of. She will come to Chennai. All
Yeah.
us will benefited. So we'll all work together,
Yes.
and Tamil Nadu ISG and Dr. Usha is there. We'll make sure that Dr. Mohan also available.
Sure.
Dr. Usha will come with the here own tutorial members. So we'll have 2 days course on Saturday, Sunday. Is it
Yes.
all right?
That will be
I will
wonderful, sir.
make arrangements for you.
Another way, if I can add, another way to do it is what we used to do for 13 years. We ran a Fogarty run program with the University of Alabama, Birmingham, UAB. 13 years continuously we ran it. It used to be a 3-day program, mostly on biostatistics. And we had the professor of biostatistics from FIU who had come to teach along with the team, one team from Minnesota and other places. So from all the medical colleges, community medicine people, we trained about 750 people we trained over a 13-year period. Now that used to be really good because what we used to do is afternoon session used to be workshop. We'll take a published paper with very bad statistics and say, what do you think is wrong with this paper? And then we'll take one which is very, very good and say, what is right with this paper? So we'll sit down and actually analyze what was done in publication. And these are in fields which you understand. If you take in gastroenterology, you think those are the ways in which you can keep on learning. So it's a lifelong learning process. But as Dr. Usha says, today is like a showing the vetting of the thing, getting your interest. Then you do a 1-day, 2-day course. Then you can do an online course. Many universities have it and it's free. Most of it is giving free. Then you also have to get certified in conducting clinical trials, GCP training. One leads to another. But ultimately, at the end of the day, your own data, if you're serious about doing research, not just understanding biostatistics, but doing research, your own data you should run through the thing. Then you will learn. And then as you write your papers, your reviewers will teach you. Definitely you learn most from your reviewers.
Okay, Dr.
One
Tayu,
broad
you have a
problem-
question to ask now?
Yeah.
Tayu?
One
Am I
problem-
audible?
Yes.
Yeah, you're audible, Tayu.
Mohan, I just, when you used to read papers, you have one entity called non-inferiority status.
Yeah.
Now, why don't you just say it's equal? Now, I read a paper on Vanaproxon being non-inferior to the other PPIs in the eradication of H. pylori. Now, why is it that we use the word non-inferiority than to say that it's equal? Is it related to the number of patients that are recruited? Or why is that word used most often in all literature?
Well, there are studies which still claim superiority. Okay. Now, earlier, the whole concept of drug discovery was if you have aspirin, okay, as a painkiller, how many times more potent than aspirin will be your next thing? That is how it used to be. If you're going to say just equal to aspirin, then we have aspirin. Why do you need something else? So that is a concept. It has to be better and it has to be safer. Finally, it comes to a stage where you've got a product which is like a gold standard. It's very difficult to, if you take the case of diabetes, it's very difficult to beat sulfonylurea and metformin even today in their potency. You have 10 different classes of drugs. They may have GI benefit, or they may have liver benefit, or heart benefit, or kidney benefit. But look at the glucose lowering. You cannot beat the sulfonylurea. It is just too good, you know. So then, if you have a product which is non-inferior to that, if you get something very inferior, then what's the point in producing it? So that is how the concept of, or you bring one class of a compound and the next one is coming. You cannot expect it to be more powerful than the other one. At least it should be equal. That is how the concept of non-inferiority. But there are companies which are coming and saying, as a primary endpoint, superiority itself. They are very confident that they will do it. So superiority trials are also coming. It's an FDA requirement. That is why there is non-inferior. You cannot say equal.
Morgan,
Equal to what?
now the
It should be
market is
non-inferior. Yeah.
the market is flooded with the vonoprazole. So
JC,
we keep reading all
JC,
the articles. Yeah.
JNT
there
will-
are some questions. There are some questions in the chat box. There were some one or two questions chat box to Dr. Babu. I have one basic question. You know, you have this meta-analysis and systematic review. What these two
Yes,
terms
ma'am.
mean? I thought it was just analysis or review of a systematic review of all the articles. So why do you have this? Should it just be a systematic review?
No.
Yeah,
And
so
you're
no, so the
analyzing
way,
it. Yeah.
correct. No, it's a very good question. No? So the way I like to tell people is, so systematic review is that there is a systematic approach to the literature search and writing the review, and the results are usually qualitative explanations of what each individual study have reported. So in that systematic review, you tell the reader that, hey, you know, we are not just doing our own search, just getting 5-6 studies. Our whole search process involved a medical librarian. It was a systematic approach. We followed PRISMA guidelines, MOOS guidelines. But then when coming to the results, it's a qualitative explanation of what each individual studies have reported. So that particular study doesn't give you a new outcome number. In meta-analysis, you are doing a quantitative synthesis. So in a systematic review, pure systematic review, there is no quantitative synthesis of or the pool rate. But with meta-analysis, now you tell the readers that we have followed everything systematically, we have done all properly, but additionally in our meta-analysis, our numbers now report a new outcome or with a new p-value, you know, if it's a systematic review and meta-analysis of randomized control trials.
And before you do that, you should look for heterogeneity within the studies, whether they're homogeneous, heterogeneous. If they're too heterogeneous, you won't be able to do a meta-analysis. So you can say we're not even attempting that.
Yeah, Dr. Mohan, what would be heterogeneity? You know, when you take a study, I think we need a little definition on that.
It depends on the, he mentioned beautifully about, I think Usha mentioned about the confidence intervals, about whether they are all touching the unity, line of unity, or they are, and how was the sample selected, everything, all contribute. There's a method of doing that also. There's something called Egger's test, which you'll know whether the samples are, the selection is there, but the bias is there in the samples that you have selected. You only selected studies which you want. All that you'll have to cross before you go. Even after that, you may not be able to do a meta-analysis. A meta-analysis is good in the end if you're able to do, because they give you a crystallized, let us say, in a systematic review, one study finds that liraglutide doesn't reduce the sugar. In another one, liraglutide or omeprazole or whatever reduces the pain by so much. Another one produces by less. And one guy says, no, omeprazole doesn't work at all. No, you've got different studies. When you put it together in a meta-analysis, no. Finally, when you see, you're getting so much effect. And it is statistically significant. For that, there's a p-value also given. Now, what you may also do is, does it work in Indians? Does it work in Asians? Does it work in white Caucasian? Does it work? If you have enough, then you will be able to split that also and say, no, this works. In fact, we published a study where we showed a big meta-analysis and system. We showed DPP-4 inhibitors work better in Asians, okay, than in the white Caucasian population. They're saying it's a placebo in US. Stop using it. We are saying it's a fantastic drug. It works very well in Asians. So that will not come out unless you pool all the Asian studies, all the European studies, do meta-analysis, then you can prove it. That's why both are needed.
Okay, 30 minutes more.
JC, Usha has a question.
Yeah, 1 minute, hold on. I will just tell a small instruction. 30 minutes more, we want a brief question and sharp answer so that we can take up more questions. Dr. Jayanti, please.
Usha has a question. Usha?
No, I just wanted to respond to the non-inferiority trial. That non-inferiority trial has, we go with the assumption that the drug may be superior, but all that we want to say is it is not inferior to the existing one. So the hypothesis testing is one-sided. It is not two-sided. That means we are not going with the assumption that the new drug may be better or worse off. We are saying it will not be worse than the existing. So your sample size changes. And as Dr. Mohan was trying to say, you already have reached the pinnacle of a gold standard. So the other drug, we are not trying to show it superior to that. We are trying to show that it is not inferior. And it may have other side advantages, maybe cost, maybe lesser side effects and other thing. And that is why nowadays non-inferiority design is becoming more and more popular.
Okay, next
There's
question.
a question in the chat box. There's a question in the chat box. How do you start a research work? And how do you think you start the question? How long does it take for an original work to get completed? Can you just tell, there are some questions in chat box asking some basic questions. How do you go about starting a research? How do you plan it? And what should you have a stop line and say I should finish by 3 months?
Very brief answers.
It depends on what your question is. And I mean, for the simplest of people, it can be just some case reports that you're publishing. Even that is a valuable contribution to a literature. It may be a side effect of a drug that you. Then you plan a series of cases that you have. That does not even need a. Then better than that is to have a case control way. Then you go to an RCT. Then, as it was shown from the pyramid, then you go to systematic analysis, and RCT is somewhere on the top. So it all depends on how much money you have, how much resources you have, how many staff you have, what data you have. Everything is research. And doing, as I think Babu Mohan and Usha said, doing some research is better than doing no research. But if you're serious, slowly you'll climb the ladder. Rome was not built in a day. Slowly only you can go.
The other important message is, like, most of the times we hand over the data to the biostatistician, all these postgraduates. And then they'll give you about 100 tables. They'll not know how to analyze it. So I think all of us should know some basics of the statistics as to, at least, should know where they're wrong.
And also know whether it's clinically relevant or not. They will come up with some association totally irrelevant. So.
Yeah, Usha, you can comment on that. Just biostatistician coming in the way of analyzing our data.
Yeah, actually, whenever you plan your study, you should be able to make your empty tables at the beginning itself. You make tables, leave them open, and begin with the data. So your analysis is already planned. And as I put up that chart, what kind of variables you have, what test you have to apply, you have your table. So then you just plug in all the values that you're getting, and then you have your data. So I do not rely on any biostatistician, because they have to first understand the concept of the study. And the concept, and if you have this little statistical tool, you can do your own analysis without having to go to a biostatistician. Sometimes some very difficult kind of analysis, you can get it cross-checked by them, but otherwise I haven't gone to a biostatistician for the last 25 years.
Sometimes, for multivariate analysis and complicated regression analysis, you will still need them, because first of all, you may not have the tools to do it. Second is that if we give the data to them, they may be able to do it much faster than we can do, and we can use our time for analysis and writing and do that. But if you are good enough, you don't even need, you can do it, yes.
Sir,
please.
SPSS has a very good software, and it keeps getting updated. Anybody who's interested in doing any research in India, I would recommend SPSS. And you have the older versions which are free, and it is not necessary to use the most recent version. And everything can be done very effectively and efficiently.
Yeah, SAS is even better if you're a little more advanced. Then there is R. There are so many simple things, and many of them are free even. And so I don't think today we have a dearth of all this. If you're really interested, you can learn. Somebody, Loganathan,
you have a question?
Yeah, it was a very interesting session that we had. I think Dr. Usha Datta's thing was more easily understood. I think it looks like a meta-analysis is going to be a very tough one, actually. looks like. I think we are learning from meta-analysis, but it's still a very tough area for probably us who are in the initial stages of the ladder. And then the cost is another thing. Like we established the normal liver function test in normal pregnancy some 20 years earlier when I was in Christian College, Bello. But that meant that we need to exclude so many things on the patient and so many other things exclusion. And for every patient, the cost was, other than LFT and prothrombin time, the cost really went up very much. It was around 3,000 to 4,500 rupees even in 1999. So cost of this basic data, to establish the basic data on with adequate power of around 200 and with the controls, imagine with all the exclusion criteria and all these things, it was phenomenally high. That's another thing area where the support is largely required. We have the data, but to put all these things into a perfect format with all the exclusion criteria and necessary inclusion criteria, we need to do compulsorily some test, which adds to the cost of it. Otherwise, it does not really mean anything. The data is incorrect otherwise. So that is another area where we need to know everything. With half data, 60% data and all these things, we won't be able to push in any information strongly to the things.
So your comment is good research come with some cost.
You need some funding also. If you want to facilitate certain things.
Yeah. Dr.
And I still, maybe another one more sentence, sir. I still remember what George Chandy used to say. I think somewhere in Australia, every patient who gets to the hospital is put into one program, one research program. That's a mandatory thing in that hospital. I do not know which hospital it is. He has been asking us to do this, but I think unless we have a program made out, we won't be able to do that actually. Yeah. Usha, yeah, please.
Yeah, just like every patient should be in one program, every doctor should answer one research question in their lifetime well. So even if each one of us answers one question well, I think we have contributed to science on which we are all, earning our living, and all things that we have got in our life is because of science. So this is one contribution we can do. So I don't think once you're taking ward rounds, once you're in the OPD, new ideas will keep coming. In my mobile, I keep noting down new ideas. And then whenever I have to give a thesis, I put it all together and then give it as a thesis.
Now, the Dr. Prem Kumar. Yeah, Mohan was asking. Dr. Prem Kumar, he wanted to ask some questions.
Unmute, Anna.
Yeah. Unmute, Dr. Prem.
Yes, sir. I would. Good evening to all. I would really agree with Dr. Paramanayakam. In fact, we recently had about sponsoring talks on how to conduct a research. As Prama told, at the end of the session, we thought that we knew everything, and once again, we're back in square one again. But to the point, I would ask Jayanti Madam, because Madam has been actively involved in research both in the government sector as in the private sector. And then what difference, because being from the government sector, I thought I'll ask, what is any difference in research activity in the government as well as in the
Recording in progress.
Okay, but in the corporate sector, you may have fewer cases and it's also expensive. So the best center or the best place where you can really work is in a public sector. And clinical research, I think to me, research is knowing what my patients have. How can I manage them? What are the likelihood that this particular patient is likely to have this particular problem? So most of my papers you will see, and I don't believe in impact factor. I don't believe in journal. I believe what Dr. Madana Gopal would say. Moment you find something, you've written something, publish it. Just house it somewhere. Because once you house it, it's your paper. So, that is my policy. I may not have a huge citation and all, but I'm quite comfortable with whatever publications I have and whatever influence I have. I know my patient. If a person comes with gallstone disease, I say, okay, this person is less likely to have gallbladder cancer. Or this patient is likely to have. So that way, or esophagitis is mild in South Indian population. That's all. Because I just to call the medical college students and ask them to fill up a paper. Do you have GR? Yes, no. They think that's all. Descriptive study. You know your patients, you know your students.
Okay.
So I think interest has to come. Interest has to come as to why. Always ask a question why. Don't accept anything at point blank, saying don't accept. Once you don't accept, that's your research take. Okay.
So you think a public sector is easier to do observational study, in your opinion, and you ask the question for the problem, you'll be able to do that. Dr. Ganesh, you want to ask some question?
Yes, sir. Good evening to everybody. Listening to the speakers and the faculty, I have come to know that research is not for the weak-heart. I think you need a lot of commitment, and congratulations to Dr. Usha and Dr. Mohan who have done exceeding. The amount of work they've done is too much. And my teacher, Dr. Jayanti, I think she's been making me to do a lot of work in Ramchandra also. So the question I would like to ask, because a lot of postgraduates have also hooked in, is their only question is to make a publication. So all they want to know is how to convert their thesis into a manuscript. I would request the faculty to probably address this issue so that most of the postgraduates would probably benefit from this.
Okay, 1 point from each faculty. We'll start from Dr. Jayanti. What idea? Then Mohan, while Jayanti is getting ready, Mohan, you want to tell 1 point how to convert your data into publication. 1 point each one. So that
for that your data has to be collected properly. So a thesis, even if it's a small thesis, as Dr. Jayanti said, a research has meaning only if it is applicable to your patients. So if you find something, which is little unusual in your population, you find cirrhosis without alcohol intake. I'm just giving you an example. Why are they getting it? Is it different from those who drink? That may be a question that a MDM student wants to take. So if you take 1,000 cases of those who drank and developed cirrhosis and 1,000 who did not, I'm just giving a rough example. And then they find maybe the age is different, something else is different. And so you collect whatever you can. And as was mentioned, without money, you cannot do anything. So if you have some funding, then you study some biomarker, maybe a biomarker to distinguish this from that. Look at the literature, see what has not been studied. Maybe you can study something. So you start somewhere, put a hypothesis, ask a question, and to answer that question, a simple thing. Okay. And as Dr. Jayanti said, it need not go into New England Journal of Medicine. It may end up in JAPI, or it may end up in Indian Journal of Gastroenterology. It doesn't matter. Somewhere you have documented it, and then future people will refer to it, and then you also get interested in that. 1 point I just wanted to make, TSC, is that you can't do research on everything. Whole of gastroenterology cannot work. Whole of hepatology also cannot work. You will have to focus. You really want to do research and shine in a particular area. Even whole of diabetes cannot work. I'll have to select certain areas. It may be type 1, it may be type 2, maybe type 2 in the young, which may be gestational diabetes. Find an area, niche area, and keep working on it. Then you will become an expert. Very soon people will realize, oh, for this, you take Dr. Nageshwar Reddy. His work on chronic pancreatitis, for the last 30 years he's been working on it. Anything on pancreas will go to him because he'll have 800 publications on that, So choose an area, focus on that, and then you will soon be recognized as a leader in it.
Your answer is focus and data has to be adequate and honest. Dr. Jayanti, you want to say something about this? How to start the publication, Ganesh thing? Or then we have a lot of questions.
I think I've already mentioned it. I think the easiest way to write a paper is start writing the methodology, That's the first thing. Start writing the methodology. That takes time. The results will be ready. Then you can finish your introduction and the discussion. And in thesis is very easy, you have the review of literature. So start writing the review of literature, but always one important thing is never start a project without an aim, You cannot keep changing all along as you're doing it. Maybe serendipitously you find something, but that can be taken as the second or the third type of a project. So to have a question, start writing methodology first. Once you write the methodology, you'll find what are the questions. And as Usha mentioned, even that's what I do. You put the statistics, you get the boxes right, put all the dummy numbers, then you know what you have to do. Is it an odds ratio? Is it chi-square test? Is it t-test? So you'll get some flavor as to what is to be done. And then with the help of the statistician, you can work on it.
Okay, I'll fire
and
now.
Simple projects.
There are two questions to Dr. Mohan, Babu Mohan.
Babu Mohan, you saw
Do you want to see that, Dr. Babu Mohan, and take those?
Yeah, I saw that. Yeah, so
Kumar. Yeah.
Yes, so I was just reading this. So for I think the first question, right, from Mukesh Kumar from Nepal.
Included or not?
Yeah.
So we can.
Sudhir Maharishi.
Okay, Sudhir Maharshi from India. So yes, so meta-analysis can be done on any type of studies. So there are one group who would only accept RCTs because then the quality of your study is really good. Meta-analysis of RCTs alone. But at the same time, I will also answer the second question at the same time. Like let's say the example of endoscopic ultrasound guided liver biopsy. Each individual paper would be talking about technical success, clinical success, and adverse events. There is no comparison. These are all like cohort studies or case studies or observational studies. You can still report a meta-analysis, pool the each individual rate. So depending on each paper's outcome, your meta-analysis would be the pooled outcome of those individual outcomes. So in this example, it will be pooled technical success, pooled clinical success, pooled adverse events. Your meta-analysis results would still be a good, or we cannot say better, but is still a data which might be better than those individual papers when you look at those numbers. I hope I answered both questions.
You made it. What is the minimum sample size required? Dr. Satyamurthy is asking for a valid study. Mohan number or Jayanti
It
Usha
depends.
numbers?
Depends. You see, if it is a common condition, you can have very large sample size. But if you are talking about, let's say, pancreatic cancer, you're working on, it's not such a common tumor in India, even today. And therefore, if you want 1,000 cases, 5,000 cases, you're not going to get them unless you pool every data in the country. So number doesn't matter. It depends on what you're. I'm studying a rare condition called maturity onset diabetes of the young. If I have 50 cases of that genetically proven, it's a very high number. It may look very small, but for that particular pure case, it's a very solid number.
Okay, for rare
Whereas
diseases,
just studying type 2 diabetes 50, it is useless,
Okay,
So
rare disease small number, but the common disease large number.
Large.
Usha, you want to answer something?
Just the reverse. Just the reverse. Large. If you have it's a common disease, you can have smaller numbers. No, you need larger number to get the smaller preference.
Where will you get it? If it's a rare disease, where will you get a large number? It's a very rare disease. Whole India, there are only 50, 100 cases. Where will you get 1,000 cases of that? You can't.
Do a multi-center study only can get such a large.
That's what.
Okay, Usha, you raised your hand.
Yeah, I think the size of the sample size which you need to give a valid answer to your question depends upon how common that disease is, so that how much you have to screen to get that number. That's point number one. Point number two is that what is the range, the standard deviation of the particular parameter you're looking at. Like, as I said, hemoglobin can vary a large amount, cholesterol can vary a large amount. So in those kind of studies, the larger the variation in that particular parameter, you will need a larger sample size. And third point, which is important, is what kind of a study design. As Dr. Mohan was saying, if he's looking for a particular kind of pancreatitis, it's just like a case control study. He's picked up those patients, maturity onset pancreatitis associated diabetes, and he will take matched controls and see what is happening. But if you are looking at for a randomized control trial, you're giving one intervention versus the other, depending on how much difference you want to see, you will have to calculate your sample size. So there is no single sample size for your question.
Okay, now we have come to the end of this scientific deliberations, and the last minute comment, we want to have something more about our faculty. We are going to have a chit chat session. Dr. Mohan, first question is to you. Now my turn to ask question to you, all of you. How do you get your protected time for research in public? Quick answer for all of you. We have 20 questions in this.
It's only passion. You have to find the time. Why am I here at 9 o'clock on a working day with you?
So if somebody says, I don't have time for research, that means he's not passionate about it.
Everybody in India I meet, every Indian doctor says, I've got a lot of data, but I don't have the time. It's not that you don't have time, you don't have the passion.
Okay. Dr. Usha, how did you develop interest in research and publications?
Well, I thought I wanted to further science. It was very intellectually stimulating to do research and to find answers to questions in my mind. In fact, as an undergraduate, I was nicknamed as Butwai because I used to keep on asking questions. So I realized I had to also answer some myself.
Okay, right.
And I at the same time.
Babu, there is an interesting question. What was your turning point in your research career or in your career? What motivated you
Excellent.
to go into systematic review and analysis?
Very nice question. So I think so two answers to that question. So one, I wanted to have something that has a rapid turnaround. So retrospective prospectus would take time. So I started with database based studies, but beyond that, I realized systematic review and meta-analysis would be a better thing to do. So once I learned that, that was a turning point. Second turning point is when I met Dr. Adler, who's my mentor, and Dr. Douglas Adler, the editor-in-chief of GI Journal. So when I met him, he's also very passionate about research and publications. Doesn't take more than 1 week to review a paper. So same thing like what Dr. Mohan was saying. Exactly what he said, sir. Like he would be editing papers in between procedures. Like he would be doing because of the passion. There's always time. So same thing what I followed. There is always time if you want to make time to to follow your passion. That's how two things
I
that
thought you
changed
were
my
going to tell about for your survival. You have to start the research.
survival. Actually, I think it was more passion that made me come all this extent. Like there are so many people like us who have come from India who want to get their green card faster. There are so many who have done that route.
Quick answer. Thank you,
Yeah.
Dr.
Thank you,
Jayanti.
Doctor.
What are the challenges you come across in publishing original articles? Pick.
As I said, I don't go for high impact journals. A journal which can publish quickly something so that the message is out. Okay. And I think each of us who is into the research, I spend half an hour every day in the evening, and just half an hour, just writing 5 lines. And over 15 days, you'll find that it's almost molded. And by 1 month, the article is there. So I think important
you will
is
challenge the challenges then. No, you will challenge the
30 minutes. This says spend 30 minutes to your paper writing whenever you have your time.
Very good. Mohan, there is an interesting question. What is the visible advantage of publishing scientific article? What do you get it?
First of all, you're learning, because to write an article you have to read all the literature, so your own knowledge has expanded. Second, your experience is something which you are now sharing with the world. So both ways, you are learning and then you are sharing the knowledge, and then of course you become visible and people begin to note, oh, this guy's been working on this. So collaborations can also start.
Okay. So knowledge gained is knowledge shared.
Yes.
Okay. Now, Mohan, there is always confusion about writing names, and your citation index also get jeopardized. So how do you write? You want to tell the youngsters right from beginning how to write a name?
So stick to one name. It's difficult for women because after their marriage, if you started long before your marriage and your name changes after marriage, it happened to my daughter. She was Anjana Mohan, and all of pre-marriage publications was Anjana Mohan. Then she became Ranjit Mohan Anjana after her marriage. And so if you see that, you'll skip some of her papers, and here you'll skip. For men, it's not very difficult. But for me, in my own case, my name is Mohan Vishwanathan, and my father's name is Mopul Vishwanathan. We're both in the same field, same diabetes, same M. Vishwanathan, same thing. And my name was cut out from 3 articles until I realized I'm going to have this problem all my life, which is the M. Vishwanathan, my father or me. So then I switched my name around and I became Vishwanathan Mohan, and I became V.
You stick to one
my own
name.
Identity. You keep to one name, otherwise you're going to, stick to one name.
Dr. Usha, your question is, how do you motivate youngsters for publication?
One second. For women, you can continue to retain maiden name as your name. So I'm Usha Venkatachalam Datta. So that is my middle name. So you can continue to have that.
You can do that. Yes. Sometimes women don't change their names also. They just keep their names. So
Usha, the question to you is, how do you motivate youngsters for publication?
I think just like every patient who has a tablet, which is because of research done on his predecessors, has a moral responsibility to enroll in a trial, every clinician who is using data to live his existence should answer one question in their lives. So every youngster should contribute in some form to science. So, and it's also very intellectually stimulating, keeps you younger. Otherwise, just following existing guidelines, you then become a medical clerk within quotes.
So one of the reasons is to keep you younger also.
Yeah.
Nice point. Okay, now one question to one word answer to all the faculty, including panelists. What is the non-medical book you have recently read? Okay, start from Usha. Non-medical Jayanti.
Dharma wala book. I'm reading Vedanta.
Okay, Vedanta. Jayanti.
I was reading a book by General A.C. Anand, Cyber. Good one.
Okay, Mohan.
Sai Baba's books.
Okay, right. Babu.
So I don't remember the author's name, but it's called the $100 Startup.
Oh, you worry all about dollars.
Trying to save money now.
Okay, Ganesh.
I'm now into little bit of Hindu scriptures, little bit.
Okay, right.
So-
And Irma?
Ikigai, sir.
Huh?
Ikigai, the Japanese.
The Japanese.
Oh, you like that book? Okay, okay.
Beautiful.
What about Ganesh? Ganesh only told now. Prem and Loganathan. Okay, now this is the Olympic time. Who is your favorite person, sports personality? Starting from Prama.
A guy from who's into javelin throw.
Neeraj.
Neeraj Chopra. Okay, right. Mohan, your sports personality.
Neeraj is.
Neeraj again. Babu.
So nobody in Olympics, sir. MS Dhoni is
Owens,
my
huh?
Alcaraz for tennis.
I thought somebody will tell. Jayanti, yours is?
Alcaraz for tennis. Tennis, Alcaraz.
Alcaraz.
Okay, Alcaraz is a young man who got it Wimbledon. Okay, what about Usha?
Olympics, it is Michael Phelps. He has 23 gold medals. Nobody can challenge that at any time.
Okay, I thought somebody is going to tell Manu. Just won the bronze medal. Okay, right. And who else there? Ganesh and Prema.
Sir, for me, I think just Dhoni. Not that I'm passionate about cricket, but the way he has been looking at and then.
Okay, Dhoni you like in all aspects as a personality. What about Dr. Loganathan? Okay, now what is the famous quotation you love to quote and really get inspired? Starting from Mohan.
Don't trouble the trouble until the trouble troubles you.
My God, it is tongue twisting someday. Okay, Prama, Ganesh and Usha.
Whatever that bronze medalist had just told us that by Bhagavad Gita says that you have the right to do your work, not to the results thereof. I mean, that is what I heard the bronze medalist told us. I thought it was really interesting. Yeah.
Okay, Usha.
Yatra Yogeshwara Krishno, Yatra Partho Dhanuddaraha, Tatta Shri Vijayo Bhute, Dhrivanite Matir. Basically, make your own Krishna awake within yourself, and like Arjuna, follow your own Krishna. So basically, self-realize yourself, become conscientious, and follow your conscience. And
Jayanti, we have
Nothing specific. Nothing specific. You tell yours now.
No, I will tell mine. Many things are there. I tell you. Now, I told you it's my turn to ask question to faculty. What about Ganesh? Anybody else you want to say famous quotation?
Look up, aim high.
Babu, yes, sir.
Yes, sir. My favorite is Karmanya Vadhikaraste Mafaleshu Kadachana. That's my favorite.
All of you got into now, all into
Gita.
Sir, Tayu, sir, what is your famous quotation?
Very simple. Look up, aim high.
Aim high always. So you are like Abdul Kalam. They dream big. Okay, now
Rajiv has one. Rajiv wants to say something. Rajiv?
Yeah. Be the change you want to see in others.
Okay,
Mahatma Gandhi.
Okay, right. Now, who is your favorite Hollywood, Bollywood, or Tollywood, whatever actor? We start from Usha.
Amitabh Bachchan.
Okay, now Prima.
Kamal Haasan.
Okay, then Tayu sir.
Rajinikanth.
Okay, and Mohan. You have to answer this, huh?
Amitabh Bachchan.
Amitabh Bachchan. Jayanti will ask who is the best actor. Huh? Amitabh. Ganesh.
Doesn't want to say a lady.
Huh?
Shivaji, sir.
Shivaji, Ganesh. Very good. Okay, right.
Rajinikanth.
Now the question to all of you is, can a clinician get Nobel Prize in medicine? If so, how and
Well, H. pylori is a clinician, isn't it?
Yeah, he got it, but after that, he got it in 2005. And what is the path then? You have to
Research.
really-
Research is only way.
It's
Clinician has to
actually
do
very
research.
difficult because it has to be for a discovery.
It has to be
So,
research.
whatever clinical work you do, you'll never get a Nobel Prize. It
Yeah.
has to be a discovery.
discovery, and otherwise you will not get it. Now 30 seconds over there, and one message to delegates. Start from Mohan. One message, short message.
Start doing research. Don't expect grants. Don't expect money. Don't expect. Start with whatever you have. Start
Jayanti?
with whatever you have.
Yeah, I start with basic clinical research with whatever you have. Whatever is around you, you do it. That's it.
Usha?
Answer one question effectively.
Effectively. What about Babu?
Same thing, sir. Don't worry about the goals. Just do your duty. I think most of the Nobel Prize winners, I don't think they ever expected to win the Nobel Prize. They do their duty, it comes to them.
More of serendipity or the accidental or.
I think so. Yeah, I don't think they ever expected. They do their duty and the prize comes to them.
And as Dr. Babu said, no, none of us have done any research work for name or fame. It is just that you just do what you're doing, and then there's some recognition somewhere around the corner. None of us did anything. Yeah, I think that's very important.
You follow your heart, answer the question
that's it.
you come across, and don't anticipate anything, and do your duty. So all these things coming towards
TC, just one word. Just one word. TC, one word, TC. I remember Suresh Chari had joined us in Peripheral Hospital, very short, I'll make it. And Mohan led us to a room in Washerman Pet, and he said, this room has about 3,000 X-rays. You analyze it and tell me what is the calcification like. I hope Mohan remembers. So we wrote the first paper on tropical calcific pancreatitis.
I remember that. The alcoholic had a different type of...
the alcohol is small stones and the tropics is big.
So
that was enough to bring a nice paper.
So we went by bus, we went by bus from Anna Nagar to Washerman Pit, taking trains. And I mean, that is what is hard work. That was a passion. Okay.
So hard work, you don't mind because you are passionate, and the result you don't bother about. All these things. Very good. I think we had a wonderful session. I must thank our speakers, Dr. Usha and Dr. Babu, and the moderator, Dr. Mohan and Jayanti, and the panelists, all of you. And more than that, we had several delegates from all over the world. They have been watching us, and they just want to know the lighter sense also how your faculty really carry the message to everyone, and it is impossible to grasp everything, as Usha told very clearly. And we are going to have a 2-day session with Usha and possibly with the Tamil Nadu ISG, and Dr. Jayanti also will join. I think with this, we'll say goodbye right now for the time being. We'll meet in August for a very important topic, celiac disease and non-celiac gluten sensitivity. And don't forget, September, the big man, the Nobel laureate is coming. He's going to talk someone very common to all the specialties. The journey of discovery of H. pylori. With this, I sign off. Thank you very much for this wonderful.
Thank you. Thank you. Good night.
Thank you, TSC sir, for this wonderful program.
Thank you.
Thank you.
Thank you, everyone. Thank you so much.
Thank you.
Thank you, sir. Thank you, madam. Thank you, everyone.